There we go. Thank you everyone for joining. We'll give it one more moment to let folks join today. Well, I will get us started. Thank you all for joining us today. My name is Tara Britton. I'm the Director of Public Policy at the Center for Community Solutions. And thank you all to those of you who have been joining us almost weekly for the last few months now to hear about the impact of COVID-19 on kind of across health and human services. We have joined with our partners at Advocates for Ohio's Future to co-host these weekly webinars to really understand what that impact is of the pandemic on the ground for our partners in food access and healthcare and education. So we really are grateful today for our speakers who are joining us to talk about how community health centers have responded and adapted in the pandemic. Just a few logistics really quickly. The slides from this webinar will be posted really soon after the conclusion of the webinar. We will ask you to submit any questions in the chat box, and we'll be monitoring those throughout the presentation. And then when we have time toward the end for questions, we'll kind of walk through those and present them to our speakers. If we don't get to all the questions, we've always been sharing them with the speakers afterward, and then hopefully can kind of connect to the folks who asked those questions and didn't get them answered in the time we have for the webinar today. Very quickly, I think most of you have seen our introductory slides for our organizations, but the Center for Community Solutions is a nonprofit, nonpartisan that aims to improve health, social, and economic conditions through nonpartisan research, policy analysis, communications, and advocacy. Our policy priorities are listed there on your screen, so really run the gamut, and are really interested always to hear what our partners are sharing with us, especially these last several months as everyone has had to adapt and accommodate all of the changes that the pandemic has brought upon us. So I am going to turn it over to Kelsey Bergfeld with Advocates for Ohio's Future to provide additional brief information and introduce our speakers today. Thank you very much.
Welcome, and thank you so much, Tara, and good afternoon, everyone. My name is Kelsey Bergfeld. I'm the Coalition Manager with Advocates for Ohio's Future. We are also a nonprofit, nonpartisan coalition of really a wide range of health and human services, policy, advocacy, and provider organizations throughout the state. We really work together to make sure that our most vulnerable Ohioans have the services and resources they need to really be successful and make sure we have strong and healthy communities. So we are really excited today to be joined by AOF members at the Ohio Association of Community Health Centers. We have three incredible policy experts joining us today. First, we'll be joined with Julie DeRossi King, the Executive Director of the Ohio Association of Community Health Centers, with Dana, excuse me if I butcher this, Dana Valengian. Something close, please, I apologize if that's totally off. And then Kelly Carey will also be joining us from the association today. So we are, again, very excited and grateful for your time this afternoon. And Julie, whenever you are ready, please feel free to kick us
off. Awesome. Thank you, Kelsey. Thank you, Tara. And good afternoon to all of you. I'm going to thank you all in advance for being kind to me and allowing me to not turn on my true camera. I was sharing with Tara and Kelsey before we got officially started that I am off today to hang out with my kiddos, and we're going to do some sprinkler fun right after this concludes. So trust me when I say it's for all of our benefits, not to show my real camera right now. But thank you all for making this a priority in your very busy days. We're really excited to be with all of you and talk about Ohio's community health centers and the impact on not only health centers, but the patients and communities served so well, and the impact by COVID-19 and this pandemic. And so as Kelsey said, I'm Julie Jurassic King. I'm the Chief Operating Officer. And yeah, the next slide's perfect. So first, a little bit about OACHC and our community health centers. Here at the association level, we serve as a nonprofit membership organization statewide, representing and supporting Ohio's federally qualified health centers, sometimes referred to as FQHCs, and then FQHC lookalikes, but more commonly referred to as community health centers. And our mission is to ensure access to comprehensive primary health care for all Ohioans through the growth and development of Ohio's community health centers. Next slide. So what is a community health center? Health centers are certainly community-based and patient-directed organizations, again, delivering that comprehensive primary and preventative health care that is delivered in a culturally competent, certainly high-quality manner. We are the largest primary care network in the state and the country. We're very proud to be a part of that. Currently, we provided care in 2019 to over 850,000 Ohioans across the state through 56 community health center organizations, comprising about just over 400 healthcare delivery sites. I think the number is 412. And we have a presence in 71 of Ohio's 88 counties. So that means we have just a small handful of organizations that are smaller in size, small but mighty, so they could be a single site organization. And then I think our largest health center in the state of Ohio has about 30 healthcare delivery sites. So of the 56 community health center organizations in total, there are over 400 sites across the state to access healthcare. And then going back to that first bullet, providing care to about 1 in 14 Ohioans. And if you look at the Medicaid program, particularly among the CFC population and including Group 8, it's about 1 in 9 Ohioans. So the mission of our health centers is similar, but we're providing that support and TNTA to the health center, so they in turn can do the real work and provide that accessible, comprehensive, and quality primary health care to our medically underserved communities and populations. There are 5 key cornerstones to being designated as a community health center. First and foremost, they're independent, nonprofit, or publicly community-based organizations. And so our publicly community-based health centers, for the most part, are born, if you will, or birthed out of a local health department, or we have a couple community-based hospitals, Metro being one in Northeast Ohio, just developed a FQHC lookalike, and we also have a health center site out of Ohio State University. Providing, again, that high quality and affordable, accessible, comprehensive care, and we are open to everybody, regardless of their insurance status or ability to pay. We must be serving a high needs area or medically underserved population. Most of our health centers are within an MUA, a medically underserved area, but you can also be designated if you are serving a medically underserved population. And last but not least, this is really, we think really cool, a great cornerstone of the health center program is that each individual health center is governed by its own board of directors, and more than 50% of the board members must be patients of the health center. And the thought there is, who knows the needs of the community better than the community members themselves or the users of the health center? So we're very proud of that, and all of our board members that volunteer their time. Next slide. Here's a map. It's getting close to a year old, so it's not completely up to date, but we are capturing where our health centers are. And so not only the organization, but where all the sites are. And so you can see where we are and where we're not, again, having a presence in 71 of those 88 counties. Next slide, great. A little bit about our patients and demographics looking from a statewide lens. We serve everybody from newborns to their great-great-great-great-grandparents and everybody in between. You'll see we have probably a larger in the 0 to 64 category, but certainly our senior population, 65 and over, we also serve as well. And we talked about earlier that we see everybody regardless of insurance status or ability to pay. We do take public insurance, whether Medicaid, Medicare, as well as private insurance, and then certainly our underserved and uninsured individuals. Underinsured is what I meant to say. And so the income levels of our patients, you know, the vast majority reside below the poverty line. And then I believe it's about 92% are at 200% of poverty or below, with just a few over 200% of the FPL. Some of the required services when you're designated through the federal government as an FQHC or FQHC lookalike in that primary preventative enabling services, you can see it's pretty comprehensive. And these services are either to be provided on site or through a contractual or written arrangement. And so from your medical primary care to dental vision service, certainly mental health and substance abuse services. Some of our health centers you're gonna find have a pharmacy on site. So really our mission is to remove barriers to accessing care. And so sometimes it makes sense to try to put all those services under one roof. Sometimes transportation is an issue, or there might be those services already in the community that you would just have a relationship with and be able to refer to. And so you can also see some of those enabling services, certainly outreach, translation is a big one in our health centers, case management, and so forth. And then these are the types of providers and the types of visits we have as well that we have on the Ohio Health Center team to make that all a reality. So you can see, while we do have a small portion of volunteers on staff, we do employ our providers for the most part and our team members. You can see in 2018, from just looking 5 years back, we were able to double the number of full-time employees in the Ohio Health Center network and just over 6,500. And I will say and put in a shameless plug, with Ohio choosing to extend Medicaid for the Group 8 population with Medicaid expansion, that had a very significant impact on our ability as a safety net provider to increase our efforts, increase capacity, hire more team members and providers, bring more of those services under one roof where that made sense, extend hours of operation, and certainly had a huge impact on workforce at our health centers. Okay, so it seems like in some ways it's been forever, and in some ways I guess it's really been since the end of February, beginning of March, that we've all been struggling both on a personal and professional level with COVID-19, and certainly our community health centers have been all in from day one. I continue to be re-energized and inspired by the amazing work that they all do facing COVID head on for their patients, for their communities, and also just as team members. I'm sad to report we just actually heard of our first loss from a community health center staff person earlier this week. And so we're just, doing the best we can and trying to do the best we can for our communities and get through COVID all together, which I'm confident we will. You can go to the next slide. So our health centers each week are reporting to their the Bureau of Primary Healthcare, which is housed under HRSA through the U.S. Department of Health and Human Services at the federal level, and are doing weekly reports on the impact with COVID-19. And so we wanted to share some of these details specifically just for Ohio. So if you visit the website, and I believe we have it linked there at the bottom of the screen, you can look at a nation as a whole, or you can go state by state. So when you look at Ohio, and it's also important to note that this is a snapshot of 1 week, and I believe this was from survey results from July 10th. And so you can see in the week ending July 10th, health centers that reported and answered the survey, which was about 75% of our health centers in Ohio for that week, tested nearly 6,300 individuals. And then if you look at who was tested, almost 31% were either of a racial or ethnic minority. And we had 516 of our patients who got tested test positive. And of those who tested positive, 55% of are either racial and or an ethnic minority patient. So pretty staggering statistics. And although maybe not so surprising, I'm really proud of our health centers who are not only testing for their patients, but are reaching out to the community. And if you remember, we discussed early on, you're going to only find health centers in a medically underserved area or working with a medically underserved population. And so I'm really proud of their work they're able to do, but those statistics certainly speak very loud to us, and they should to all of us. Next slide. Kind of a same week, July 10th, from the same survey. Just wanted to kind of give you a flavor of what COVID impacts look like on the operations and staff of the health center. Currently, only 27 sites have temporarily closed, and when the pandemic first struck and when Ohio was shut down more or less, I think that number was close to about 100 out of our 400 plus sites. So it certainly had a greater impact that the health centers have started to recover from. And so looking at about 27, when at one point in time we were at 100, they've made great strides. We do have some staff that continue obviously to test positive, only 4 in that week that of the health centers that reported. But we, just like everybody in every workforce and labor force, we have certainly our staff members that have other restrictions, whether the site or the service line that they support, like dental was a big one. When dental operations shuttered except for emergency only, they may have not needed the entire dental team, although many health centers kept open their dental operations even for emergencies. And some were able to deploy those team members to maybe another service or site within the health center network, but certainly that had an impact. And then we all have our family and home obligations or come into exposures and you're quarantined or self-isolated. And certainly lack of PPE, just like the rest of the country and across the state of Ohio. PPE has been a big struggle. I would say it's ebbed and flowed. There have been some really low points and then some high points, trying to connect the health centers with resources, specifically PPE. And I think this snapshot in time for the week of July 10th, only reporting that low of a number, near 8%, is pretty good compared to weeks in the past. And then the average percent of health center visits conducted virtually. I know Dr. Dana and Kelly will talk a little bit more about the impact that our virtual visits and our ability, thank goodness for both Medicare and Medicaid and many of the commercial insurers following suit, but our ability to connect with our patients virtually through telehealth has been just really life-changing, not only for health center operations, but more so for our patients. So that's been great. That's actually I'm surprised to see it be that low, quite frankly, at 37%. Again, just 1 week in time. I think the week before it was over 50%. I know at the peak of the pandemic, going back into late March, early April, we were hearing from some of our rural health centers that 95% of their visits were being conducted virtually. And I think a lot of our patients have really enjoyed that connection virtually. And I don't suspect, I think, you know, as Seema Verma well said at CMS, now that the genie's out of the bottle, I'm not sure we're going to put the genie back in. And I would wholeheartedly agree with that. I think we need to look at, you know, what works, what doesn't, and, you know, work to perfect, but certainly be able to continue the trend that we're seeing with the use of telehealth and telemedicine. So now I'm going to turn it over to my colleague, Dr. Dana Valangian. She's our Chief Medical Officer. Dr. Dana?
Good afternoon, everyone. Hopefully you can hear me loud and clear. This has been a week of technical difficulties for me, so hopefully those are not plaguing us today. At any rate, thank you so much for allowing us to join you today. It's a pleasure to be here. By way of introduction, a little bit more for me. I am a family physician as well as an addiction medicine specialist, and I have had the pleasure of being at OACHC for a little over a year. And prior to that, I was working at Mary Haven as a medical director for a year and a half. But most of my healthcare work has actually been in community health centers. I spent 17 years as a CEO and a provider at a health center here in Columbus. And so health centers and the patients that we serve are a passion for me, and love to have the opportunity to share what's happening inside health centers. And so I'm going to do two things today quickly, talk to you about the state of testing and give you some updates about what that looks like, and then to talk about the state of what patient care looks like for health center providers and patients. So on the testing front, next slide, please. Health centers have been very busy over especially the last 8 weeks, and they've done a phenomenal job in rapidly increasing their capacity and ramping up the ability to test for most of them, not only their patients, but also their community members. And this has been in spite of a lot of intricacies, very rapidly moving details and changing details almost daily. Health centers have really been able to put together testing in some unique and innovative ways. And so as we talk about testing, there are some important concepts to understand for COVID testing. First is capacity. And here in Ohio, we actually have capacity in two ways. We have private capacity for testing, which comes through LabCorp, Quest, other commercial labs, private hospitals that aren't part of the state testing capacity. And then we have the ODH and about 8 or 9 hospital labs that are part of the state's testing capacity. There are multiple types of COVID testing. So there's diagnostic testing, which includes viral or PCR tests, and these tests can be done either rapidly, point of care, or go to the lab, either the state or the private labs to get resulted. And then we have antigen testing, and there's really only one rapid test right now that is an antigen test. And then the second kind of main bucket of testing types for COVID is serology or antibody testing. So the diagnostic testing is all done, I should say, with a respiratory specimen or a swab, whereas the serology or antibody testing is done currently with blood. And there are multiple types, rapid, lots of different rapid tests. Most of those are not reliable and not really allowable to be used in most of our health center settings. And then we can draw blood and send it to the lab for antibody testing. The jury is still out on antibody testing as far as what it means tied to immunity and how useful it is in knowing what's going on with a patient for most patients. So our health centers have really been focused for the most part on the diagnostic side of testing. And virtually all of them are offering PCR and viral testing. The bulk of that is being done through labs, mainly commercial labs. And a few of them have been fortunate enough or already had the point of care and rapid platforms. And so a few are offering kind of rapid testing either viral testing or antigen testing. And then there are varying methods of deploying testing. Most of our health centers are doing some level of ongoing testing, so having it available in some regular fashion. Some are doing pop-up events with the National Guard. Others are finding other community events and community places to offer testing. I would say most health centers are doing some combination of all of this. There are many health centers who are testing widely, meaning their community members and their patients. Some health centers, you need to be a patient to be tested, but they are accepting new patients, and so there's access that way. Other health centers are only testing their patients currently because either their community doesn't really need anything beyond that, or they have some limitations. So some of the challenges have been for health centers, the moving target of testing supplies, whether that's the swabs, the reagent, the transport medium, all of that has been an issue. Julie's already mentioned the PPE issue. Turnaround times were very long to get patients their results originally. That got much better. And now in the last week to 2 weeks, those turnaround times are again increasing, and it seems to be affecting certain commercial labs, somewhat the state system the most right now. And we've already discussed, you know, if you don't have adequate supplies, if you're struggling with turnaround times, that can sometimes affect the ability to open this up very broadly to your community at large for testing. So the caveat on testing really that I want to leave you with is that all of our community health centers are engaged in this work. They want to be a foundational piece to helping with this for their patients and the vulnerable in their communities. However, because of some of these constraints and rapidly changing things, it is really important that patients are directed to call their local community health center to find out what is going on at this particular day and point in time for them, and the community health center can then help guide that patient or community member to either their own testing or to testing that they are aware of in the community. And so I think that is the quick summary on testing and the state of testing. So I'm going to switch gears and talk for just a couple of minutes about the state of patient care and what it looks like day to day right now inside a typical health center. So patients are being asked almost universally to call first, and that's not just about COVID testing. That is if they are ill. Health centers want them to call first, and they really want to take that opportunity to be mindful with each patient about whether it's best for them to be instructed to come in person or to be scheduled for a virtual visit. Health centers are really, for their established patients, trying to individualize care right now so that patients with chronic conditions or high risk are going to be continued on telehealth visits and only come in person and minimize in-person exposure for things that are important like labs or an occasional in-person visit. So really calling first if they need a test, calling first if they're ill, just calling in general. A lot of health centers are doing reminder calls the day before or 2 days before patient appointments, and they're using that opportunity to again help tell the patient whether they are to come in person or how to connect to their telehealth visit. If they are coming in person, they are going to be screened at the door or before they get to the door for whether they have COVID symptoms and temperature. If they do have symptoms, they are likely not to be turned away, but instead directed to a isolation room or taken through so that they don't expose many staff or other patients. And they will then be assisted with getting the COVID testing and or the health care that they need to determine what's going on with their symptoms. If the screening is negative for any sign of COVID, then they're going to proceed with their appointment. Universally, patients are being asked to wear masks. Universally, staff are wearing masks. Health centers are doing all the extra cleaning and distancing precautions that they possibly can. Some health centers are separating sick patient visits from well patient visits or routine patient visits, trying to keep those two ill and well patient populations from commingling in waiting rooms and space in addition. The other thing that I would say is that health centers never closed. Even when we were on stay at home and kind of shut down orders, health centers continued because the work of taking care of patients never stops and has to continue. But what that did back in March and April was rapidly force health centers to figure out how to deploy telehealth platforms and telehealth visits for their patients. And so over 90% of visits back then, very rapidly within 3 to 4 weeks, went from in-person to all virtual. And as Julie's already mentioned, we're now kind of rebalancing that pendulum, and we're back between 30 and 40% of visits being telehealth. Health centers did an amazing job in figuring out how to deploy this technology and do it in ways that made it accessible for the majority of their patients. That was also greatly helped by the ability to have telephone only count as a virtual visit. And so that has helped really, even I still practice a day a week, and in my own experience, that has greatly helped with continuity of care. And we're actually connecting with patients that wouldn't come and hadn't sought care because they're more comfortable and more amenable to doing that first, second, third, fourth visit by telehealth and not coming in person. I practice MAT, and we have our medication-assisted treatment for opiate use disorder, and we also have a lot of patients who we've been able to connect to treatment for the first time by the flexibility of these current rules and the current environment, allowing us to initiate treatment by telephone visit. We have a lot less no-shows too. So those are some of the very positive silver lining things that have happened in the middle of this pandemic for us in health centers and for our patients. It's also been the health center's focus to remain comprehensive in our services. And so we've been able to deploy telehealth really across multiple service lines. You heard Julie speak to some of the challenges with dental, and I would say that has been the service that has been most affected and most limited, but even there, the priority has been maintaining access for patients to at least emergency services. Health centers have gotten really creative in chronic disease delivery, and I think that innovation and creativity will continue over the next 6 months. Some health centers are doing drive-up blood draws so that patients don't have to come in. They're doing drive-up hemoglobin A1C checks for patient sugars. They're deploying remote patient monitoring devices that help make the telehealth visit and knowing what's going on with your patient's blood pressure, weight, sugar more meaningful from a distance. There are 2 ongoing current themes for our health centers, and that's what I will close with. We are concerned over delayed care and the impact of delayed care in both our immunization and childhood adolescent space, but also for adults with preventive care and with what they need in chronic disease management. So we will continue to try to do what we can to push that forward, even as we continue to live with COVID. The second area of ongoing concern and priority is to use COVID in this current pandemic and somewhat the need that folks feel for testing and that we need to do for testing, especially in some of our vulnerable populations. We really want to leverage that to not just get them tested, but to take the opportunity to get them linked for chronic medical care and primary medical care so that every Ohioan has a primary medical home. So thank you for allowing me to spend a few minutes updating you on what's going on with our health centers with testing and patient care. I really appreciate it. And I am going to hand things off to Kelly Carey, who I think is going to talk about some of what we've seen with policy during this time.
Thank you, Dr. Dana. As she said, my name is Kelly Carey, and I'm the Director of Policy and Public Affairs at the Ohio Association of Community Health Centers. And my job today is to just talk about some of the policy reforms that we have been working on either before, during, or will be doing in the foreseeable future. So the first one is the preservation of Medicaid coverage and services. As Julie mentioned earlier, thanks to Ohio being one of the states that expanded Medicaid coverage, eligibility levels and coverage we have seen has been directly associated with ability of community health centers to invest in primary care. Like Julie mentioned, it allowed us to open more sites, provide more services, expand hours of operation, hire more staff, and just better meet the needs of the communities that our community health centers are in. Well, right now, as many of you probably have seen or read, Ohioans are losing their health insurance through their employers, and they're becoming newly enrolled in Medicaid as a result of the pandemic. So we need a viable and stable Medicaid system in the state. So the need to preserve Medicaid is both vital now and going forward. We are about to go into a budget cycle at the state where we do need to have a balanced budget. And Ohio right now is facing anywhere from a $2.9 to a $3.4 billion budget deficit. So anything is on the table right now. And they're already having discussions on if there needs to be changes or cuts to the optional services. So of concern, that's areas such as adult dental and vision, prescription drugs, vital services that we provide to our patients. So at OACHC, we think it's imperative that we continue to advocate for continued coverage and services at the state level. But the state can't do it alone. So recently, OACHC, along with a lot of the advocacy groups, including AOF, have made a call to action to our Senators Brown and Portman, asking them to increase the FMAP, which is the Federal Medical Assistance Percentage Rate, to 14%. Some of our individual community health centers reached out, our national association reached out to stress how important it is that we increase this and provide some relief to the state. We have to ensure that a solid safety net is in place with adequate funding, or otherwise we are going to lose some of those viable services and be in direct competition with things like education and emergency services. The next area that we were working on both before, during, and I think in the foreseeable future is telehealth. Julie and Dr. Dana mentioned how vital it's been for our community health centers, not only keeping their doors open, but also just providing the care that's needed out in the communities. And they did turn it on very quickly, and the resources that are needed to do that are some of the areas where we've been advocating, and then also the flexibility. So as previously mentioned, community health centers utilize it in a number of ways: general medical care, mental health evaluations, oral health care. All these areas we were able to show both the state and the federal that it is desperately needed, not only during the pandemic, but probably into the future. So on the federal side, there have been several pieces of legislation expanding telehealth, even past the pandemic, and providing resources for providers and broadband expansion. OACHC has been very supportive of those efforts. And on the state side, per the governor's executive order, when he declared a state of emergency, Department of Medicaid issued rules allowing some flexibility in the telehealth space. And then most recently, they issued another set of emergency rules, expanding and improving on those rules and allowing them to be in effect until November 14th or until they file a permanent rule. And as Julie said, it's hard to put the genie back in the bottle. So we do hope and foresee that telehealth will be able to be utilized into the future. And some of the areas where we worked with Medicaid on these rules was exactly the flexibility that Dr. Dana mentioned, where, allowing forms of communication that don't have to have audio and video elements. Telephone calls, fax, email, and also allowing individuals to access the telehealth services wherever they're located. That can be their home, it can be schools, it can be temporary housing, hospitals, nursing facilities, and then allowing the providers themselves to deliver the services from any location, including their own home offices and other non-institutional settings. It allowed the flexibility for providers to meet the patient where they're at. And so we will continue to advocate for this flexibility and making it permanent, along with, although commercial insurer payers have been following suit, we're hopeful that there will be some parity in that space as well. Oh, 340B, Federal Discount Drug Pricing Program. I will not jump into the weeds on this program because it is very complicated, but it is a very valuable program for our community health centers. So in a nutshell, 340B provides eligible providers access to drugs at reduced prices, and then the savings are passed on to the patients through services and access to medications. So health centers are one of the eligible providers, but we are required by law, regulation, and mission to invest every penny of the 340B savings into activities that expand access to care for the medically underserved patients. So as you can imagine, the first obvious way that community health centers can use these savings is lower prices of medication, but they also use it for things like dental or substance abuse treatment services or dietitians or diabetes or counseling. The 340B savings really do go far and beyond to help serve the underserved population. Well, unfortunately, this program has been under attack at both the federal and state level. At the federal side, nationwide, we've been alerted that CVS and Caremark is limiting their reimbursement for certain drugs, and basically it eliminates the savings produced from the 340B program. And then you have drug manufacturers Eli Lilly and Merck, who have recently taken actions targeting health centers and other 340B providers, their ability to use contract pharmacies to distribute medications to their patients. Well, in the community health center space, this is huge because majority of our health centers don't have in-house pharmacies. So they use contract pharmacies to provide medications to their patients. So if manufacturers start down this road, it is gonna greatly impact how community health centers can get the needed medications out to the communities. So on those, we are working with our national association, NAC, on a PR and a legal approach to make sure that the 340B program is secure and as intended. But unfortunately, it doesn't stop there. We have been seeing some action at the state level from pharmacy benefit managers for the past couple years, where they're issuing contracts to our community health centers, where they basically say, take it or leave it, we're taking your 340B savings. And unfortunately, community health centers are not in a powerful position enough to tell them to leave it. So they're in a situation where they either have to say, no, we will not sign that contract, and then they will not be able to provide the access to prescriptions for their patients, or they have to take a credit contract and lose out on the 340B savings. So we have been working with legislators, both in the House and Senate, on legislation. It's House Bill 482 and Senate Bill 263 to prohibit actions like these where they basically target 340B providers and take the savings and put it in the pockets of the PBMs. Both bills are out there pending and we will continue to push forward on them, but it's an uphill battle for sure. So while the pandemic was going on, as Dr. Dana talked about and Julie talked about, community health centers were on the front lines and they were impacted big time. They're still impacted. And so we thankfully have strong bipartisan support and did receive some emergency funding in the supplemental and stimulus legislation for COVID-19. That included testing, tools to support responses like telehealth policies, equipment supports, as well as community health centers are also small businesses. So they were included in the practice release reports of those. Unfortunately, more is needed. As Julie talked about, we are not up to pre-COVID visit numbers, and the loss of patient revenue is extremely difficult on community health centers. And there's still a fear of public not going to the doctor. So we do need additional resources. And we are happy to see that the House recently passed the HEROES Act, which successfully included $7.6 billion in emergency funding for community health centers and lookalikes. And also said that health centers over 500 employees are eligible for the Paycheck Protection Program. We are hearing the Senate is expected to release their next COVID stimulus package. And we are hopeful and have been hearing that it also includes the $7.6 billion in emergency funding, and as well, hopefully, some additional funding for the Provider Relief Fund. At the state level, we have been in constant communication with the governor and his administration, as you heard about the pop-up testing with the National Guard. And although no direct funding has come from the state to us, we have had some successful partnerships with them. Some of them, like I said, you did already hear about the pop-up testing, but some that you might not have heard about we did partner with the Department of Health to distribute 5,000 thermometers to health centers in order to get them into the hands of patients who may not be able to get them themselves. The state did provide 36,000 PPE items to community health centers for our frontline providers. And then we also partnered with Nationwide Insurance Foundation and the Department of Health to provide community wellness kits to testing sites to be dispersed out into the community. And these kits included masks and hand sanitizer and disinfectant cleaner. So we'll continue both at the state and federal level to advocate for the resources needed, not only during this pandemic, but for the times to come ahead. But I'd be remiss if I didn't talk about overarching all of this is our long-term community health center funding. It feels like eons ago that they were talking about the budget at the federal level, but community health centers are operating under what's called a continuing resolution. And so it is not long-term or stable or guaranteed. So as small businesses, health centers can't operate on such short-term certainty. They need the stability to know that they can hire more staff, that they can be innovative. I mean, I think we all know that the public health issues are still out there, even though the pandemic is what everyone's talking about. There's still opiate addiction. There's still HIV. There's still maternal mortality. Areas that the community health centers are on the front lines providing services and helping out on. And so we do need that long-term funding to be able to move forward. So we, along with our national association, are advocating for a 5-year extension of community health center funds, and then also funding for our National Health Service Corps and Teaching Health Center graduate medical education program. So those are our priorities right now on policy and advocacy. And I'd have to do a shout out that if all the voices are singing the same song, and this is some areas that you could get interested in. Kelsey, if you'll go 2 more slides. Thank you. At the bottom of that page is you can become a community health center advocate. You can sign up there and you will get emails from us, and I promise we will not flood your inbox, but it will give you an insight on some of the areas that we're advocating on, some information on what we're working on, and opportunities for you to take action as well. And with that, I think I'll turn it back over to you, Kelsey.
Thank you so much, Julie, Dr. Dana, and Kelly for a really insightful, informative presentation. I better understand kind of how everything is fitting together now, and it's really just incredible the work you all are doing in the midst of all of this. So thank you so much. We did receive some questions through the chat as well as the Q&A. I did see that I think some of them were answered already, but Ebony, do you want to help us get through the questions just to make sure that we've captured them all? I will read.
I can do that.
Oh, thank you. Go ahead.
So the first question is, when you do telehealth, how do you actually examine the patient's body, blood, etc.?
This is Dr. Dana. Thanks for that question. That's a good one. And so there are devices that can be utilized to assist providers in doing that. Some of that is the remote patient monitoring devices I mentioned. There are other kits that allow health centers to deploy something for telehealth or have the patient use for telehealth, a device that allows the provider to listen to the heart and or look in the throat and ears. So some of it is using that type of technology. Some of it is very low technology, like instructing patients to show rashes on camera if you are doing a video AV type of visit. And utilizing the patient a bit more to be an interactive part of helping with that exam. Some of the time you are sacrificing exam and that exam capability, but for a lot of what we do as clinicians, the history and that good communication and information that your patient provides, studies have shown that that can be up to 80% of what goes into making your diagnosis and treatment plan.
Thank you. I think we have one more. A question regarding your patient board members. How are they recruited and who gets to pick them?
Well, this is Julie. The health center leadership team, the CEO or executive director, ultimately responsible for building and recruiting its board of directors. They may use some board-to-board member outreach or potential member outreach as well. But I would say to all of you or the person who asked the question, if you're interested in volunteering at your local community health center, I would certainly encourage you to reach out and inquire about existing opportunities or to keep you in mind for future opportunities. Again,
Julie,
yeah, please do, Dana. And just real quick, the big takeaway is going back to the top of the webinar, the cornerstone, one of the cornerstones of a community health center is being directed by patients and users of the health center. There are some other parameters that the health centers have about their board members. I believe no more than 10% of board members can have their income resulting from healthcare. So you're not going to have like all hospital folks on the board, and the size of the boards. There's a minimum and a maximum number of board members and things like that. Dr. Dana, were you going to add something?
Sure. I was just going to add a little bit more of maybe the practical real world logistics. I know like most health centers have a board recruitment and application process that Julie is speaking to. Practically speaking, a lot of times providers assist in identifying patients that are interested in the board or that would make a good community representative on the board. And then a lot of times the patients or health center patients, users themselves, when their term is close to ending, will help actively in the nomination process of who is going to take their seat. And then functionally, the board itself is who actually officially votes those new members on.
Great, thank you so much. I know one other question came in through the chat. I wondered if anyone wanted to expand a bit on the nutrition services that you all provide at community health centers. And then I think that covers the others in the Q&A.
I can go first, and then Julie can maybe give a broader picture. As far as nutrition services, that looks, I think, pretty different and unique depending on each health center. Definitely nutrition is something that all health centers are cognizant of, being a social determinant of health and access to healthy, fresh foods being important. So that may look like the health center's screening for access to healthy food, and then making some referrals and or working with other community agencies around access to food. Some health centers directly employ dietitians and make that part of their core medical services. And so they're having their diabetic, hypertensive, other patients routinely work with dietitians on improving their diets. Other health centers are directly providing access to fresh food themselves and healthier foods themselves by either creating pantries or nonprofit grocery stores for their patients and community.
And I'll just add, and I think we have Pat McKnight, at least at one point was on the webinar, and I believe asked the initial question. And so I have to give a shout out to Pat. A few years back, Ohio Department of Medicaid, I believe, was the first in the country to initiate reimbursement for certain dietitian services provided by Medicaid providers. And not to get too weedy on you, but the way community health centers are paid under the Medicaid and Medicaid program is through a prospective payment system called PPS. And it's more of a, based on the health center's cost, they do an initial cost report. And so regardless of what happens in that visit with the patient on that day, if it's your strep throat and ear infection, you get the same medical rate as if it's for a comprehensive diabetes, it just doesn't matter how many codes are in the visit of that day, they receive the same medical rate. And so for a long time, having a dietitian on staff was a struggle because we couldn't seek reimbursement for their services outside of how health centers are typically reimbursed. But Medicaid, and Pat was an amazing advocate, and so I applaud her. I applaud the Department of Medicaid. They did enable us to be able to bill for those dietitian services on a fee-for-service basis outside of and in addition to that initial medical rate. And so we have seen a dramatic uptake and integration of dietitians and into our community health center practices. So thank you, Pat, for all you did and continue to do.
Thank you. I have one other question that I am just sort of curious about after hearing, a lot around the COVID testing and kind of where we're heading in terms of the governor's, I think, hope that we can get to a point where we're doubling the amount of tests that we do in a day in the state. And I just wondered, I'm sure you all are having, you're a part of those discussions and conversations, and I'm just curious kind of what you think, or where you think we're headed in terms of expanding testing capacity, getting to a point, I think testing is going to be a part of all of our lives for at least the next several months, and kind of what role you all will continue to play in that.
It's an excellent question. This is Julie, and I'd ask my colleagues to jump in as well. I think Ohio under Governor DeWine has made really great progress. We were initially just testing, for those that are familiar, certain prioritized populations, and they were largely those who were really sick and showing symptoms of COVID, or if they had pre-existing conditions and were sick. Our healthcare workforce or essential employees, as well as folks in the congregate settings. And then as we initially then moved to community testing, so even folks that had symptoms or were asymptomatic, we were trying to open up testing to everybody. And I think that's where community health centers have played a really big role. I will say, Tara, it's a great question because not unique, unfortunately, to Ohio, but the rest of the country is really struggling with getting the testing supplies, the adequate PPE, and then we're also seeing increased demands at our labs. So I would say the majority of our health centers do not have lab services in-house, but take the specimen and send it out. And so our private lab partners, they're experiencing, I've heard actually last night heard the worst I've heard so far was 20 days. And that's just not even impactful or useful at that point. So that's a real struggle. I think, one of the keys to certainly fighting and combating back on the virus is widespread community testing. We're struggling now with, other partners in the state and across the country. I do take to heart, though, that I know the governor has tasked his team, and as a result, all of us here in the state of Ohio, to figure it out, because I don't think anybody wants to go back to just testing certain segments of the population. And certainly when you think of it with for minority health purposes in that lens, we really need to continue to make our underserved communities and populations a priority and make sure they have access to testing. So if anybody has a really good in with a lab partner or PPE, we are taking any and all help we can find, but it's something we continue to work on every single day. It certainly is a challenge. And so to some extent, I know some folks are frustrated because they can't get a test. And I have friends and family that have been exposed or experiencing symptoms, and it can be, especially depending on where you are, is challenging. So we will continue on.
Thanks so much, Julie. And I will turn it over to Kelsey to wrap us up and give a preview for next week.
Absolutely. Thank you so much, Tara. I know we have another question or two outstanding. We'll be sure to connect those folks with our presenters today. And again, want to thank you for your time this afternoon. I know I learned a lot about especially telehealth services. I think it's so interesting. And the ability for community health centers to kind of mobilize that process and expand it so rapidly during the time of immediate crisis was just so impressive. So very quickly, wanted to give you a brief preview of our next web coming up Friday, July 31st. That will be our finale for our COVID response policy webinar series here for this summer. And we will be doing a brief overview of the topics that we have covered since April 3rd. It's been quite a journey. We've reached out to all of our presenters over the past 16 weeks for any kind of updates or kind of last final messages for our viewers concerning the topics that they've covered, and we're really excited to bring you some new updates. We are also excited to confirm that we have 2 elected officials who will be joining us to talk about how they've been helping their constituents in their districts deal with the impacts of COVID and making sure that they are getting the resources they need to their community. So we will have State Representative Janine Boyd from the Cleveland area joining us, as well as State Senator Stephanie Coonsey from the Columbus area joining us next Friday, July 31st. So we hope that you can tune in, and we look forward to you closing it out with us over this past few months. Have just been such a joy. And we will be restarting our kind of joint webinar series again in the fall, hopefully in early part of September, having more of a budget focus and an outlook. We know that those budgets are going to be interesting, and we know there's some deficits that our elected officials are going to have to deal with. And we know advocacy is going to be incredibly important moving into our next state budget process. So thank you again to our presenters and for joining us this afternoon. It was so enjoyable and so enlightening, and keep up the work that you are doing for communities and patients across Ohio. So please enjoy the rest of your day. Have a great Friday, and we will see you next time. Thanks, everyone.
Thank you.